Hello, Assalamu alaikum. My name is Dr. Tajvur. I'm going to talk today about managing lupus in pregnancy. This is quite a complex topic, and I've been given about 20 minutes or less. So hopefully we can discuss a few issues around this. I'm going to mainly discuss this by discussing a few scenarios, asking a few questions, and then inshallah afterwards, I may be available for answers. So I have no conflict of interest. Some of the drugs mentioned may be off-label, and this is not a comprehensive review. If further information is needed, it would be important to discuss or review papers, articles, etc., and I can be contacted for that. Right. So we're going to discuss a few diagnostic dilemmas in pregnancy, some treatment options for complicated pregnancy, and how to manage difficult lupus. Okay, so the first case is of a 32-year-old lady who has been diagnosed with lupus. She is now 34 weeks pregnant and presents to clinic with bilateral leg swelling. About 6 years ago, she was successfully treated with cyclophosphamide for class 4 lupus nephritis, which has since then been relatively stable. 4 years ago, she had new onset proteinuria, microscopic hematuria, and RBC cast. She was treated with cyclophosphamide again. Then 8 months ago, her urine, 24-hour urine demonstrated 1 gram of protein, no cells, and her creatinine was 1 milligram per deciliter. Her blood pressure was just above normal at 148/90. She did not have a history of hair loss or lesions, no arthritis and no rashes. She does have 2+ edema in both legs. Now, so the question is, which of the following criteria is most compatible with the diagnosis of preeclampsia? So we want to know, she does have a little bit of high blood pressure, she has edema. So the question is this preeclampsia or is this lupus? How will we differentiate? So you have 4 scenarios here. So for creatinine, it can be either normal or high. Uric acid can be normal or high. Her calcium can be normal, low, or high, and her urinary sediment might be absent or present. So which one of these do you think fits best with a diagnosis of preeclampsia? I'll give you a few seconds to look. Okay, so the correct answer is number 3, C. So serum creatinine relatively normal, high uric acid, calcium 60 milligrams, urinary sediment absent. So the question is, how do we differentiate preeclampsia from a lupus flare? So the main thing is the timing. As we know, preeclampsia will usually occur late towards the end of pregnancy. So more than 90% will occur at 34 weeks plus of pregnancy, whereas a lupus flare can start relatively early. The blood pressure will be very high in preeclampsia. There will be significant proteinuria. Urine sediment will usually be negative or bland. Transaminases will be very high. The white cell count can be raised about twice of what it has been during pregnancy prior to this. There can be thrombocytopenia, and this can be a major feature, albeit this can sometimes occur in lupus as well, as you know. Uric acid is usually high. Complement levels will usually be normal, and headache is very common. In a lupus flare, can occur anytime. Blood pressure can be a little bit raised. Proteinuria might be present. Urinary sediment will be positive. Transaminases usually normal. White cell count normal or low. Thrombocytopenia, as we said, plus minus. Uric acid, there is no reason for this to be increased. Complement will get used up and therefore will be low, and occasionally patients can complain of headaches. Okay, next scenario. Which of the following antiphospholipid antibodies, if present, has the highest predictive value for pregnancy loss after 12 weeks gestation? So as in second trimester and beyond loss. So which of these antibodies is most important to predict this? So the options are anti-beta-2 glycoprotein 1, anti-cardiolipin antibody, lupus coagulant, or previous pregnancy losses. So which one of these will predict? Correct answer is lupus anticoagulant. So in a place like Pakistan, where your patient has limited resources and these tests can be expensive, if, for example, you had to choose to do just one single antibody, then I would suggest you do the lupus anticoagulant. This confers most of the risk in these cases. So according to research, this is a study done in 144 patients, in which 28 patients had adverse pregnancy outcomes. So when they checked, 39% of patients with the lupus anticoagulant had adverse outcomes, compared with only 3% of patients who had this antibody negative. So amongst the patients with anticardiolipin IgG, if the level was more than 40, which is quite high, about 5 times above normal, even then only 8% of those who were negative for the lupus anticoagulant had an adverse pregnancy outcome. But if there was anticardiolipin IgG as well as lupus anticoagulant, then the pregnancy loss rate was about 43% in these patients. Anticardiolipin IgM, anti-beta-2 glycoprotein 1, IgG and IgM, in this series did not predict adverse pregnancy outcomes. In a bivariate analysis, adverse pregnancy outcome occurred in 52% with and 30% without previous thrombosis, and in 23% who had lupus as well, and 17% without lupus. So lupus was a predictor. Previous pregnancy loss, according to this particular study, did not suggest adverse pregnancy outcomes. If there was simultaneous positivity for anticardiolipin antibody, anti-beta-2 glycoprotein, and lupus anticoagulant, it did not predict the adverse outcomes much better than just lupus anticoagulant, suggesting that lupus anticoagulant has the highest risk with it. It's the most important out of all of these. Now, this is another study, PROMISE study. This is very well quoted. Anywhere you talk about pregnancy and lupus, this study you will always come across this. It's one of the most important studies that has been done. In this, there were 385 patients with lupus, and on the other side, there were 198 healthy controls to identify which were risk factors and what was the mechanism of adverse pregnancy outcome. In these, 81% patients had uncomplicated pregnancies. Now, adverse pregnancy outcomes were more common if the patient was non-white, as in African Americans, Hispanics, and I would suggest Asians as well. If the BMI was more than 30, if the lupus anticoagulant was positive, if there was low platelets, low complement 3 and 4, if antihypertensive drugs needed to be used, if there had been a lupus flare in the 2nd or 3rd trimester, if the glucocorticoids were not necessarily associated with adverse pregnancy outcomes, and novel markers were identified. Endothelial growth factor was also identified as a risk factor. Now, out of these, which would you think are most important as a risk factor? It was found that non-white ethnicity, so African Americans and Hispanics, that was important. Lupus anticoagulant positivity, if the platelets were less than 100, and if antihypertensive medication was used. Just by the side, I will also let you know that there has been studies done in Birmingham, UK, by the professor I have had the pleasure to work with, where we've noticed that if one white English person has had lupus, it's been 2.5 times more common in Asian people, and that's across the board, all Asians, and 8 times more common in Afro-Caribbean people. So lupus tends to be more common in certain ethnic groups. Now, So out of these, a model for fetal loss in pregnancy showed the following variables, which all independently predicted fetal loss after adjusting for confounders. So again, which of these do you think are more important? Unplanned pregnancy, low complement, presence of anti-dsDNA, meaning positivity or high, pre-pregnancy hypertension, or proteinuria. So which three of these do you think carry the highest risks? So unplanned pregnancies usually carry higher risk, low complement, and proteinuria. Now, these three variables independently predicted the risk after adjusting for confounders. So the odds ratio for unplanned pregnancy was 2.84, and you can see the confidence intervals. Low complement, 5.46, so much higher risk, and 24-hour urine protein of more than 1 gram, odds ratio 5.8. Now, the risk score was calculated by the following equation. The fetal loss risk score was unplanned pregnancy, 1.04, plus low complement, 1.7, plus urine protein, 1.7. The risk was then divided into low risk, if the answer was 0 to 3, high risk, 3 plus, with a sensitivity of 60% and specificity of 93%, positive ratio of 9.03, and a negative likelihood ratio of 0.42. Now, so we'll talk about family planning and pregnancy, issues for women with systemic inflammatory illness. So there's been some studies looking at patient and physician perspective. Sometimes they can be different. As a physician, we may not entirely understand the whole perspective from the patient's side of view, point of view. So there's been 2 large surveys which covered UK, France, Germany, Italy, Spain, and USA. These were women aged between 20 to 45, premenopausal women. There were 250 rheumatologists and 100 gastroenterologists who covered the frequency of discussion and the patient satisfaction with the discussion. So it was noticed that 32 to 56% of the physicians spontaneously discussed family planning issues. Most rheumatologists, 74 to 92%, and gastroenterologists at 74% reported having discussed conception or pregnancy when they were prompted. Less than half reported specifically contacting their patients or treating GP or gynecologists or obstetricians. So this is just a short summary of this particular paper. So when in the last 3 medical appointments, the patient was asked what was discussed. So you can see emotional well-being, employment, sports, family life, social life, and only after that having children and pregnancy was discussed. And remember, these patients are 20 to 45-year-olds. Having family concerns ever been discussed? It looks like Italy and Spain are much better, as well as France. And then Germany, US, and UK seems not to be doing as good at discussing these. Now, is it a concern from the patient's perspective or not? So as you can see in the table here, that has been sort of highlighted or encircled. Most people between the age of 25 to 39, it did concern them. Almost 2/3 of patients did have a concern about this issue, about family planning and pregnancy. They did want to know about it. Now, so patients were asked, how often would you like the topic to be brought up? So most people said when a decision needed to be made or if it impacted the family. 1/4 of the patients, less than that, thought just once is enough. 15% plus wanted to discuss at every visit. Reasonably, patients said they wanted to discuss when the medication was being changed, at least once a year. And about 5% patients said every time when my patient is stable enough to become pregnant. Now, what prevented this discussion coming up? And this is the patients would have said, I forgot. The healthcare professional didn't seem to have the time. I didn't want to change my medication. The healthcare professional I'm seeing can't help us and they don't have the experience in it. They're reluctant to talk about it, and other. So what can we do to discuss pregnancy risk assessment? So unplanned pregnancy, as we know, can be during active lupus, at the time of conception. There might be teratogenic drugs being used. These are a risk. If the complement levels are low, this can lead to adverse pregnancy outcomes. A positive lupus anticoagulant, as we said. Proteinuria is very important to know about prior to pregnancy and also to check during pregnancy. So I would recommend doing a urine RE at every visit. I'm sure you're already doing that. A previous history of thrombotic events. To note the blood pressure reading, BMI if it's more than 30, the presence of Rho and La antibodies, SSA and SSB, because naturally this carries the risk of congenital lupus, congenital heart block during pregnancy. Now, so what would be a good management approach? I would suggest preconception counseling. Avoid unplanned pregnancy if you can. So when you're prescribing medication, very clearly tell the patient these medicines are not appropriate to plan a pregnancy, or this is not a safe time to plan a pregnancy. Try to defer a pregnancy until the lupus is in remission for at least 6 months. I attended a conference, ICON in Karachi last year in January, 2 years ago actually now. And I remember that everybody who was there, different specialties, whether they were gastroenterologists talking about IBD, diabetologists talking about diabetes, this seemed to be a standard that if the patient was in remission with their general condition, if they were stable for 6 months, then pregnancy seemed to be safer across the board for most conditions. It is important to use HCQ throughout pregnancy. It's a safe drug, and studies have shown it improves pregnancy outcomes. It is important to discontinue teratogenic medication, and if possible, avoid abrupt withdrawal of all medication, which might lead to a lupus flare, even though the patient is stable at the time when you are changing the meds. Low-dose aspirin does seem to improve pregnancy outcomes, especially in patients who have positive antiphospholipid antibodies. Perhaps all lupus patients might have it. The risks are relatively low. Low-dose aspirin, as well as low molecular weight heparin, is important if you have antiphospholipid syndrome, where you have history of miscarriages, previous intrauterine growth retardation, or preeclampsia as a history. It does improve outcomes up to 80%. The benefit can increase up to 80%. If there is a previous history of thrombosis, then definitely I would recommend both aspirin and low molecular weight heparin. You can look up resources at this particular website. I would say pre-conception counseling is very, very important. Have a particular appointment to discuss this when the patient appears they're ready for pregnancy. Thank you.